Good evening, everyone. Welcome to tonight's Wu University webinar, Urgency of Retinal Referrals, and we're really excited to have Dr. Sherrol Reynolds live tonight. I'm your host tonight, Dr. Jennifer Stewart. Welcome again to Wu University. I'm really pleased to introduce tonight's speaker. Dr. Sherrol Reynolds is a graduate of the University of Florida and Nova Southeastern University College of Optometry. She's an associate professor of optometry at Nova and the director of the retina clinic there. She's a fellow of the American Academy of Optometry and the Optometric Retina Society. She served as president of the National Optometric Association from 2017 to 2021 and currently serves as past president. She was awarded the National Optometric Association Optometrist of the Year in 2013 and also the 2021 Women in Optometry Leadership Award and the American Optometric Association 2020 President's Award. She's a planning group member of the NEI National Eye Health Education Program and the current co-chair of Eye Health for African Americans. She's participated in numerous events addressing diversity, inclusion, and equity in the profession, and is the member of the Prevent Blindness Scientific Committee. She's served as the chair of the Florida Optometric Association Healthy Eye, Healthy People Committee, Women in Optometry board member, and a monthly columnist for the Optometric Management Journal Retina column. She's the only optometrist who contributed to the 2022 American Diabetes Association compendia that provided healthcare professionals with up-to-date information and best practices for treating diabetes.
Well, I want to thank everyone for inviting me. Thank you, Wu University, the entire staff for inviting me. I hope everyone is having a wonderful night. Thank you, Dr. Stewart, for such a great introduction. So really quickly, just a few things, my disclosures that are listed here. I'm a speaker, I receive honorarium from the various companies that are listed. And really importantly is that all financial relationships have been mitigated. We have to put that in for COPE approval. So tonight we're going to spend the next 15 minutes or so talking about those retinal conditions that require urgent referrals or emergent referrals. And so part of the learning objectives for tonight's presentation is to discuss essential tools and examination of the retina for assessment leading to proper diagnosis and referral of conditions requiring urgent referrals, appreciate multimodal imaging that can be used to help us facilitate a diagnosis and the referrals to the next level of care, and discuss the clinical course and expected outcomes for commonly encountered retinal conditions that require urgent referrals, and review some management strategies, the latest update, preferred practice guidelines for some of these commonly encountered retinal conditions that we see in our practices that sort of require urgent referral and or emergent referral. I want to start off with one of the conditions that we commonly see, right? Patients that present to our office with acute symptoms of floaters and flashes of light. A lot of times we look at the retina and we anticipate to find that these patients have what is called a posterior vitreous detachment, right? And if you look at this patient right eye, you probably think that this patient has a complete posterior vitreous detachment or PVD. You think that there's a Weiss ring. And then in his left eye, you can see quite a bit of vitreal condensation in this patient. So the question is, does this patient have a complete PVD process going on? Is there something else going on? This patient was really complaining about his right eye as opposed to his left eye. And when we did an ancillary test, an OCT testing, you can see that although we see what is thought of as a Weiss ring, in most cases, a Weiss ring don't necessarily mean that there's a complete PVD detachment. So it's important to do ancillary testing. It's important to really follow the patient's chief complaint that they have. And you can see in this patient's OCT presentation that the patient has traction, or still there's an attachment of the posterior hyaloid onto the optic nerve head. So this patient has what we call vitreopapillary traction syndrome. Is this an emergency? Is this an urgency for the patient? Not necessarily, but it is important to know that patients that have vitreopapillary traction syndrome require careful follow-up. But then there are those patients that present that complained of floaters and flashes of light. This patient also complained of a central vision defect in her left eye, and it's been going on for a few months. Interestingly, her vision is 20/20 in her right and 20/20 in her left. And if you look really carefully at the dilated fundus assessment, you're really not seeing anything that really points to what this patient is complaining about. But then when you do in your OCT testing, you could see in the right eye that the patient has a vitreomacular adhesion. The patient wasn't complaining about this eye, but this eye is interesting. It has a story of its own, and we'll present that in just a few minutes. But in the left eye, the patient's complaint of a central defect, you can see that the patient has a vitreomacular attraction syndrome. So you can see that the patient has a focal defect. But what's interesting to note is if you look more carefully, there's a subtle outer retinal change. And so the question is, when we see patients like these, should the patient be referred emergently or immediately to the retinal specialist? I was very concerned about the patient's outer retinal defect. The patient complained of a central vision defect that was also seen on AMSA grid testing. Is this patient having a stage 1A macular hole based on the old criteria? Is this an impending macular hole? So I did call my retinal specialist colleague on call just to sort of solicit some advice for this patient. I did show the imaging to my retinal specialist colleague, and he felt that I can follow this patient a little closely. And he said, Dr. Reynolds, bring the patient back in about 3 weeks, really assess again. Of course, we want to always educate our patient if there is increased floaters and flashes to come back immediately. But this patient came back in 4 weeks, and you could see that that defect, that focal vitreomacular traction defect, has really become a little bit more. You can see that the patient has an intraretinal cystic change in the inner retina, as well as this outer retinal defect. At this point, I do feel that this patient needs an urgent referral to the retinal specialist. So again, I called my colleague and we took a look at my imaging so that he can see, and he wanted to see the patient. And not even 3 weeks later, the patient developed a full thickness macular hole. So the question is, when do we refer patients with vitreomacular traction syndrome and patients that come in with acute PVD symptoms? And really quickly, this is a patient after she had macular hole surgery. 6 months later, you can see disruption of the internal limiting membrane. She had an ILM peel with the macular hole repair. And then in her right eye, the eye that is better vision, she started to have some symptoms. And as you could see from the previous OCT, was a vitreomacular adhesion. So should we be following vitreomacular adhesion syndrome more carefully, bringing these patients back when they have VMAs, maybe in 3 months, just to make sure there's no changes? And this case kind of highlights following patients very closely, because you could see she has now a focal VMT and she has a partial thickness or lamellar hole that's developing in her right eye. And she was very concerned because she already had a macular hole in her left eye. And you could see that after following her with the retinal specialist, that she has a complete detachment of that posterior hyaloid membrane and some intraretinal cystic changes that's causing some subtle vision changes for the patient. She still is 20/20 in her left right eye and about 20/25 in her left eye. So this patient was very concerned, but we're following her very closely. So let's talk about vitreomacular traction syndrome then and now. So we know VMA, really the definition of that is that the macula is undisturbed. There's no changes in the macula, but it is important to follow these patients closely just to make sure that there continues to be no changes. So I recommend seeing these patients every 3-6 months with vitreomacular adhesion. With vitreomacular traction syndrome, there are changes or disturbance to the inner or outer retina. When are we concerned about patients with VMT? Should patients with vitreomacular traction syndrome be referred on an urgent basis? And really quickly, before I answer that question, I just wanted to sort of highlight again from the vitreomacular traction study group some changes that really puts the patients at risk. The patients that have more of a focal VMT are more likely to develop some sort of complication, whether it's intraretinal cystic changes or maybe a macular hole development. Patients with broad VMT are not as at risk, but it can cause subtle changes in the vision. This image here is an optometrist that presented with a complaint of anisoconia. As soon as he said anisoconia, I knew that he was an optometrist. So these patients still need to be followed. So what are some predictors of vitreomacular traction release, or things that we could see in our patients that give us a little bit less anxiety in following these patients? Really, if there's no outer retinal disturbance, when we see these inner retinal changes, because you can have both inner retina only or both inner and outer retina, like in my patient that I showed you. But if the patient just has inner retina changes, they're up to 32% more likely to have some sort of spontaneous resolution of their vitreomacular traction process. But however, patients that have outer retinal defect, like the patient I showed you, my patient, they're more likely possibly to develop a macular hole. So these patients, I definitely sort of consult with, refer to a retinal specialist. In my case, that patient developed a macular hole pretty quickly. So you want to follow those patients very closely when they have outer retinal defect. So again, any sort of outer retinal defect, you want to follow the patients closely. Now, in the past, you had Vitrea, which was a treatment for patients with stage 1A or B macular hole, or even stage 2 macular hole. I don't know of any retinal specialists that are treating patients with Vitrea anymore. That increases the vitreolysis that can occur for patients. And vitrectomy is a procedure that has a lot of risk, so it is important to follow these patients. But when we talk about macular hole, what is an urgency, what is an emergency? Really, when you have different types of macular hole, for example, this small size macular hole, because in 2023, we're really classifying macular hole based on size. I know we have gas system of 1A, 1B, but now we really want to classify if it's small, it's less than 250 microns. And if it's medium, it's 250 to 399 micron in size. And then if it's large or extra large, it's 400 or greater micron in size. But what's important to note is that the small to medium macular hole changes should be referred urgently to a retinal specialist, because these patients tend to do better. The outcome of surgery is a lot better for these patients when you refer them sooner rather than later. The other thing that we want to look at when we look at macular hole, is it primary or secondary? And of course, is there presence or absence of vitreomacular traction? Another thing we want to look at is stages of macular hole as it develops. It could be this foveal detachment. You can get partial thickness, and you can definitely get full thickness macular hole from a vitreomacular traction. And this chart just really kind of compares the old system between, gas system of stage 1A, 1B to the International Vitrectomy Treatment Study Group, and what they classify macular hole as small, medium, or large. But going back to what I said earlier, small or medium macular hole, they need to be referred within 72 hours. It's important to get those patients in within 3 days. If a patient presents with an earlier small size macular hole, I would even recommend an impended macular hole for consultation with a retinal specialist. One study found that the closure rate the success of surgery was 90% for small to medium hole. Of course, if patients have large hole and it's acute, it just, may have happened recently, then it's important to refer those patients. Chronic holes, or holes that have been there for a long time and are large, those are the ones that don't do as well. And some retinal specialists may not even do surgery on those patients if they have a retinal hole for a very long time. The prognosis is not going to be the same as a smaller, medium, or acute macular hole. So that's macular hole. So please refer those patients if you have floaters and flashes, and you're not sure, perform OCT. They could have vitreomacular traction syndrome. All right, the next case I want to present is a patient who presents, our most feared one, a retinal detachment, right? So here's a patient with an inferior retinal detachment, but surprisingly, his vision is not bad at all. He did have that curtain or had some changes in his vision, not a curtain, but, a shadow in his vision as a complaint, and floaters as well. So the thing is, the vision is pretty good, but it looks like that fovea, that macula is on. So is the fovea on or off? Well, always good to do an OCT. And here you could see that this patient's retinal detachment, that there is some foveal attachment for this patient. So that's why the patient's visual acuity is relatively very good. So again, should this patient be referred immediately to the retinal specialist? When we talk about retinal detachment, what's an urgency and what's an emergency? Patients that present with a MAC on retinal detachment as opposed to a MAC off, we know that MAC on is the most important. And if a patient presents with a macular on retinal detachment, they should be referred the same day to a retinal specialist for consultation. So you want to get them in as quickly as possible or within 1 to 2 days to preserve vision. Surgery should be done within 24 hours. And if surgery is done in a quick, timely fashion by the retinal specialist, the patient's prognosis for visual recovery or sustaining the vision that they have is pretty good. So just as a reminder, any MAC on retinal detachment is an emergency. It needs to be seen as quickly as possible, including the same day with the retinal specialist. There are some risk factors for progression to MAC off if patients have, macular on retinal detachment. One of the biggest risks, and I put things in red that I really want to highlight, is whether it's a superior retinal detachment. Superior retinal detachment, superior temporal retinal detachment is just like a MAC on for me. It's an emergency or urgency. It needs to be seen within 72 hours, right? Because we know gravity pulls things down. So superior temporal retinal detachment needs to be seen as quickly as possible. If there's a large retinal dialysis or a retinal detachment or a bolus retinal detachment, these patients need to be seen in a more urgent manner within 72 hours of their seeing the patient. I do want to mention in a recent publication that was published not too long ago that although, MAC off RD, sometimes you're seeing, it doesn't have to be seen by the retinal specialist as quickly as a MAC on retinal detachment. A new study found that we used to think it was 7 to 10 days, but there's growing evidence that earlier intervention, usually typically within 72 hours, that's 1 to 3 days, it may improve outcome. So therefore, it's really important to refer these patients with even MAC off retinal detachment as quickly as possible so they could be evaluated by the retinal specialist and have surgery as quickly as possible to improve their visual recovery and outcome. So the typical thought was 7 to 10 days. We're now thinking it's about 72 hours or within 3 days. There are some other things that are ominous sign that we should look for as optometrists when patients present with floaters, flashes, changes in the eyes. If they're having a retinal detachment, we want to look for tobacco dusting or Schaefer sign. Vitreous hemorrhage can occur in patients that have posterior vitreous detachment or PVD. And if you have a patient that has vitreous hemorrhage, that's important to refer the patient as well as inflammatory cells, and the patients might have other causes for their retinal detachment. And so you want to look for those as well. And really quickly, we know some of the managements for retinal detachment, and it's here on the slide, laser, scleral buccal vitrectomy are some of the options for our patients. But even once they have the surgery, it's important to follow these patients to make sure that the edge of where they do it for laser is well attached, even with scleral buckling procedure that is well attached, because they can have another retinal detachment as well if it's not. And with posterior vitreous detachment, floaters and flashes of light, one of the key things that I want to remind my colleagues to look for is a retinal tear. Assume there is a tear and, really look carefully. We should be scleral depressing these patients, making sure that there's no retinal tear. And if there's no tear or you don't see one and you're not sure, you might want to refer that patient in a timely fashion between 1 to 3 days for evaluation. And also too, if you're comfortable, you did scleral indentation and you're not seeing a tear, we want to educate these patients to please return to the clinic if there's increase in their floaters and flashes of light as quickly as possible. Other things that I want to mention, I mentioned it earlier, just with posterior vitreous detachment, acute floaters and flashes, patients might have hemorrhages, small hemorrhages, like in this case here. This patient had an inferior juxtapapillary hemorrhage. That might be an indication. You might want to follow the patient very carefully. In this particular case, the posterior hyaloid was really pulling on the optic nerve head and the vasculature around that, causing that hemorrhage. And this was a case too where if we talked about vitreopapillary traction syndrome, it looks like the nerve is swollen. But again, this patient had vitreopapillary traction syndrome. And anytime you see a retinal tear with an associated hemorrhage, that's an urgent referral that needs to be evaluated by a retinal specialist as soon as possible. I do want to highlight the preferred practice guideline that is published by the American Academy of Ophthalmology for posterior vitreous detachment, retinal breaks, and lattice. But one of the things I want to highlight here for us as eye care practitioners is that patients presenting with an acute PVD and no retinal breaks have a small chance, about 2%, of developing that break in a week that follows. So if you're not seeing a retinal break, you're unsure, refer. If you did a scleral indentation, you're still not seeing a retinal break, you might want to bring the patient back sooner rather than later because they're at risk of developing a retinal break or a tear within a week or so. So you want to follow these patients very closely. And then again, I wanted to highlight this case. This was a patient that presented to my office. The patient had acute loss of vision. There was a vitreous hemorrhage. The patient was referred. She came back in and we saw some subtle changes in the vasculature where the hemorrhage was. And when we did an OCT on this area, you can utilize your OCT for peripheral imaging as well. So that if you see changes in the periphery, you can bring your line raster over to that peripheral area. You could see that this is where that PVD caused a change in the blood vessel, a break in the blood vessel that led to the vitreous hemorrhage. It almost looks like there's a macular hole here, but this is in the inferior temporal quadrant of the retina. And you could see where that posterior hyaloid sort of pulled on the vasculature and caused a disruption and caused the vitreous hemorrhage. All right. The next case I wanted to highlight is a patient that presents, and this was a patient of mine, 75 young, and she has, of course, advanced age-related macular degeneration. In her right eye, you can see the subretinal hemorrhage here, clearly indicating that the patient has, gone from dry AMD to wet AMD. But look at the patient's left eye. Interestingly, she's complaining about loss of vision in her left eye. It has suddenly gone darker in her left eye. And you see massive exudation and hemorrhages in that left eye. And that really kind of indicates that this has been sitting here for a long time. And a lot of times patients aren't aware that they're losing vision in one eye when they're already visually compromised unless they close one eye. And this is what happened to the patient. She was doing something and she happened to cover her right eye and noticed that she can't see that well anymore in her left. And you could see that she clearly has massive changes indicating that she has a choroidal neovascular membrane. And here is the OCT and OCTA just highlighting that the patient has a choroidal neovascular membrane. So the question for my colleagues is, when should we refer patients that have a choroidal neovascular membrane? Should they be referred urgently, a week for these patients? And in some patients, it's easy to see, like in that patient. In some patients, it's hard to see. You have this patient who presents, you can clearly see that the patient has early dry AMD in the right and intermediate AMD in the left, and they were complaining about metamorphopsia on AMSA grid testing. So, multimodal imaging really helps us to delineate or to really, facilitate the diagnosis. So you can see these intraretinal cystic changes on the OCT, line raster, and then on OCTA, you can clearly see that there's a choroidal neovascular membrane in the patient's left eye, and the patient was referred. It's important if you suspect a choroidal neovascular membrane in our patients with AMD that you refer these patients in 1 to 3 days, 72 hours. It's found that these network of new blood vessel can grow 5 to 10 microns per day. So the quicker they are assessed, evaluated, and the quicker they are treated with antivascular endothelial growth factor, the better the prognosis for the patient. Now, there are some patients that will develop a choroidal neovascular membrane that may not need as urgent evaluation. This is a case of a patient you could see in the right eye, extensive geographic atrophy, fibrotic changes from a prior choroidal neovascular membrane. And in her left eye, of course, she has, extensive geographic atrophy, pigmentary changes, but you could see the hemorrhages indicating a new choroidal neovascular membrane. But this patient also has glaucoma. If you look at the patient's optic nerve head cupping, and although this patient has a new choroidal neovascular membrane, a rebleed of a choroidal neovascular membrane, she did not want to go back to a retinal specialist for treatment. She's had numerous treatments already. So this patient elected not to go, but also I didn't felt it was an urgency that this patient was seen right away within 1 to 3 days. This patient was scheduled for an appointment in a week or so, but refused to go to the retinal specialist. So there are some cases where, especially if they've had multiple injections and you have these recalcitrant network of new blood vessel, choroidal neovascular membrane, that you can follow these patients very closely. But if you have a patient who has sudden loss of vision, sudden change in vision, metamorphopsia, and you see a choroidal neovascular membrane, in 1 to 3 days is the appropriate time to get them to the retinal specialist. And I want you to remember that there are other causes of choroidal neovascular membrane, choroidal rupture, angioid streaks, and conditions such as Paget's, Ehlers-Danlos, presumed ocular histoplasmosis. We're seeing the patients myopia is a big area of interest right now, and one of the leading causes of loss of vision in patients with myopia. It's pathological myopia, and one of the conditions we see is the development of choroidal neovascular membrane from a lacquer crack. And then, of course, patients that can have polypoidal choroidal vasculopathy can have choroidal neovascular membrane as well. I just really want to quickly go over some current treatments that are available. Your standard antivascular endothelial growth factors, your Avastins, Eylea, and Lucentis. Vabysmo is a new, or Vabysmo, some people say Vabysmo is a new medication that is bispecific. It has both, anti-VEGF properties and angiopoietin 2 blocker. So it's an Ang2 blocker. Angiopoietin has been found to be very important for vascular stability. And so angiopoietin 1 keeps our blood vessels in our eyes stable via Tie1, and then Ang2 comes in and disrupt that network. So Vabysmo sort of block that pathway as well as the vascular endothelial growth factors. So it's a new medication that's out there. The Vabysmo is that port system, and recently it was recalled in October 2022 for that, so no one is really doing that as much. This patient, when we see, patients that have hemorrhage or acute loss of vision in the back of the eye, including vitreous hemorrhage, a lot of times those are urgent evaluation in an emergency room for some patients, but we see them as optometrists. If the patient has vascular etiology as a cause, whether it's diabetic retinopathy, causing the vit heme, it may not be as urgent of a referral, of course, these patients needs to be referred to a retinal specialist and have treatment. A lot of times, some of the retinal specialists may wait till the blood sort of, if it's a full vitreous hemorrhage, till it kind of comes down a little bit or improves a little bit, or they might inject right away. But this patient had acute loss of vision after coughing, and you could see that the patient has a pre-retinal hemorrhage and then a little bit of fluid. This really is Valsalva retinopathy, and it looks scary and it should be referred to a retinal specialist, but a lot of times the retinal specialist might follow these patients. You could see here that without treatment, you could see resolution of the hemorrhage or improvement of the hemorrhage over time. Usually within weeks, it can improve. It's just important to find out the etiology of what caused the Valsalva retinopathy. But let's talk about diabetic retinopathy, because a lot of times we have patients in their chair, they present to us, they have diabetic retinopathy. When should they be seen by the retinal specialist? And this is a 55-year-old patient that presented, and you could see in the patient's right eye that they have massive neovascular changes, that the patient has exudative changes. In fact, you can even say that the patient's macula here, this part right here, this retina right here is the only healthy retina per se. The patient has a lot of fibrotic scaffolding, exudative changes, and macular edema in the right, and same thing in the left. So when do we want to get these patients to the retinal specialist? And really quickly, should they be referred immediately to the retinal specialist for treatment? One thing that I want to point out is the high-risk characteristics of proliferative diabetic retinopathy. If our patients with proliferative diabetic retinopathy has these high-risk characteristics, then they should be seen as urgently as possible, typically within the same day or within, 72 hours. And what are those high-risk characteristics? They are neovascularization within 1 disc diameter of the disc, or between 1/4 and 1/3 disc area and size of the disc. And then, of course, any neovascularization of disc associated with a pre-retinal or a vitreous hemorrhage, and then any sort of neovascularization elsewhere associated with a pre-retinal or vitreous hemorrhage. So any of these high-risk features require us to, not require us, but I would say that these patients need to be seen by a retinal specialist urgently for evaluation. And I just want to point out with this case, I like this case. This is a unique patient of mine. Sometimes it's only the neovascularization of the disc that the patient might present. And if you could look at this patient's right eye, you could see that the patient clearly has neovascularization of the disc, very minimal retinopathy changes in the retina. We might see some dot and blot hemorrhages, some exudative changes, and of course in the left eye, it's completely healthy. There's nothing going on. I do want to point out, anytime you do see asymmetric presentation in retinopathy, you want to think carotid artery disease. You want to have those patients assessed. Up to 10% of patients who have asymmetric diabetic retinopathy have some sort of carotid artery disease and are at risk of having a stroke. And this is just a closer look at the optic nerve head. And this is the patient a year later, comes in. You could clearly see that it's only MVD that the patient has, if you look at the patient's left eye. But going back to when should these patients be referred, this is just a quick overview of diabetic retinopathy and the risk. When they have mild retinopathy, there's a 5% risk of these patients having proliferative disease, within a year. So you want to follow them very closely. I have 12 months, but I would even recommend 3 to 6 months, depending on the patient's overall health. The patient might have elevated A1C levels, really uncontrolled diabetes. So I want to see them sooner rather than later. Moderate, these patients are up to 27% more likely to develop proliferative disease in a year. So of course you want to follow these patients very closely as well. And this severe, up to half of these patients are at risk. But anytime we see those high-risk features, Of course, proliferative diabetic retinopathy, we want to refer to a retinal specialist, but any of those high risk characteristics, they need to be seen by a retinal specialist within a day or so. I would even say 1 to 2 days, they should be seen by the retinal specialist for evaluation, consultation, and more than likely treatment with antivascular endothelial growth factors. But what about macular edema? I always get these questions about macular edema. Not that there is an urgency or emergency to patients that have diabetic macular edema. It's important for us to assess whether it's center involved versus non-center involved. OCT is really great at helping us to delineate that. Of course, when you have center involved, your central subfield thickness can be greater than 305 in women and greater than 320 for men. But if they have thickening, especially center subfield thickness, that's your center involved diabetic macular edema. These patients should be seen within 1 to 2 weeks by a retinal specialist. And of course, there have been studies, protocol V, that sort of assess for patients' visual acuity with center involved DME. And, if the patient has good visual acuity, 20/20 or 20/25, vision, these patients can be followed very closely as opposed to having treatment initiated as far as anti-VEGF. So again, vision is important, but if we do see center involved diabetic macular edema, it's important to refer those patients. For non-center involved DME, we can follow those patients if we're comfortable as optometrists, maybe see those patients back in 4 to 6 weeks. If you're not comfortable and you see any layer of diabetic or any stage of diabetic macular edema, you might want to refer those patients to the retinal specialist for consultation. 9 times out of 10, patients with non-center may not be treated. They may be assessed and evaluated and followed very closely. Some doctors may elect to do light laser, focal laser treatment for non-center involved DME. This patient with underlying vascular disease comes in, and you can clearly see that this patient has changes from hypertension. The patient has diffuse cotton wool spot throughout the posterior pole. The patient has macular edema, the macular star appearance. And then if you look at the patient's left eye, the patient clearly has some changes as well. This patient's blood pressure was significantly elevated. This patient's blood pressure clearly indicated that this patient is in distress, and the patient's clinical presentation clearly indicates that this patient is an urgent emergent referral evaluation. And then here are the OCT, just highlighting the sensory detachment that's going on in the macular area. So when we talk about blood pressure, this patient's blood pressure is very elevated, 195 over 120. What is your diagnosis? Of course, malignant hypertension is what this patient has, and how should this be managed? So I just wanted to kind of recap hypertensive crisis, or patients that have hypertension that can lead to a crisis. And I really want to underscore the importance of doing blood pressure assessment for our patients in office. I'm not sure how many optometrists are doing that, but we recently had an episode where a patient's blood pressure was very, very elevated. Of course, we want to look at other neurological symptoms. If it's just a blood pressure and there is no changes in the eye, I always say urgency. You might see stage 3 hypertensive changes, but these patients will have elevated blood pressure in your office, but no end organ damage. And, blood pressure, hypertensive retinopathy is a target organ damage. Of course, the retina is an organ and it's damaged from high blood pressure. But what I mean by end organ damage is loss of life, conditions where the central nervous system, the lungs, the hearts can be impacted. Patients will present shortness of breath as a symptom that with their elevated blood pressure. Patient might present with dizziness, severe headache. We know throbbing headaches are an indication of high blood pressure. And also patients might have nausea and vomiting as signs and symptoms. And even for our pregnant patients, maternal health is a big area of concern and issue. And one of the things we see with maternal health this significantly elevated blood pressure. And so these patients present who are pregnant that potentially have an elevated blood pressure, they have other symptoms, they need to be seen as quickly as possible, as urgently as possible, because the blood pressure is impacting them. So again, target organ is the eyes, yes, but end organ is where you can have the potential for loss of life. These patients who have really elevated blood pressure and have an urgency, a lot of these patients have their medication, they just don't take it. That's why blood pressure is called a silent killer, because again, there's very few symptoms unless it's in the very end, high stages of the condition. And all these patients need to do is take their medication, not so much going to the emergency room. So we could definitely consult with their physician, make sure that they're taking their blood pressure medication. Usually they have it in their purse. Make sure that they're taking their blood pressure medication right there in the clinic if they have it. If you're uncomfortable, we can definitely refer to the hospital. But again, urgency, there's no end organ damage. Emergency is really elevated blood pressure, severely elevated, and there is a potential for loss of life. And again, remember, the emergency, these patients may have additional neurological symptoms and or they may have sign of malignant hypertension. We have optic nerve head edema and the macular changes. These patients, the goal for hypertensive emergency is urgency is to reduce blood pressure, initiate medication, increase dosage of dose of existing medication, or add another medication is what the PCP will do, or reinstitute medication for patients that have stopped taking it. However, for emergency, these patients need to go to the hospital, and it needs to be a 911 call. You cannot tell these patients to drive themselves to the ER, and you can't tell them to Uber to the ER. I wouldn't recommend that. This is a 911. These patients need to be assessed urgently, emergently in your office and taken to the hospital where they can get emergent care. If they go in, a lot of times there's a wait, but if they go in with the ambulance, then the patient will be treated emergently. What's the goal of treatment for patients that have malignant hypertension is to slowly reduce the blood pressure via IV. We don't want to reduce the blood pressure quickly because the patient's at risk for ischemia, potentially a stroke, but to reduce it over time. What's the key thing with malignant hypertension? If these patients aren't seen, and if they're not treated, there's a 50% risk of mortality at 2 months. And that risk of mortality increases at 1 year if they're not treated. They're not going to see the year. So malignant hypertension is a medical emergency in your office. If you see patients that present with malignant hypertension, please call 911. When it comes to vascular occlusion, really quickly, I just want to recap that. Patient has either a non-ischemic or ischemic CRVO. Which one is an emergency? Should they go straight to the retinal specialist? Typically patients that come in that have non-ischemic CRVO, I like to do additional testing. These patients have a better chance of recovery. The leading cause of vision loss in patients with vascular occlusion is macular edema. So we want to also rule out concomitant macular edema. We're going to follow these patients very closely. I don't necessarily refer these to retinal specialists if it's non-ischemic. I follow them very closely. However, if they do have macular edema, I do have my retinal specialist colleagues see these patients within, a week or so. Is when I would definitely have these patients be seen. They don't have to be seen urgently. For ischemic CRVO, these patients come in with an apparent pupillary defect, loss of vision, sudden loss of vision, widespread capillary non-perfusion. We don't need to do fluorescein angiography. You could do OCTA. We have montage OCTA. You could see a lot of capillary non-perfusion. These patients are at risk for the 90-day glaucoma. But these patients I do refer out due to the loss of vision, the apparent pupillary defect for consultation. A lot of times these patients are seen by the retinal specialist. They may have concomitant macular edema that needs to be treated with anti-VEGF treatment, and of course, follow these patients for the 90-day glaucoma. Here's a patient that presents with another vascular occlusion, an artery. You could see that, the retina is pale. You can even see that the patient has a plaque in the superior artery here. But this 89-year-old came in with sudden loss of vision. You can see the cherry red spot. And here on OCT, what you're seeing is not so much that there's fluid here, is that the retina is so swollen from the ischemia. So the initial presentation is the cherry red spot from the initial insult to the retina. So it's swollen, and that's what you're seeing. And then, of course, there's a shadowing here that gives this appearance that there's fluid there, but there's no fluid. It's just because the retina is swollen. Well, in 2023, how do we treat central retinal artery occlusion? It's an emergency. These patients need to be seen by, emergently stroke center risk. You want to refer these patients to a level 4 hospital that has stroke capacity to assess these patients. So any patient that presents to your office with a central retinal artery occlusion in 2023, they need to be seen urgently, emergently. And patients that have branch retinal artery occlusion should be seen as well, but definitely central retinal artery occlusion, ophthalmic artery occlusion. These patients should be seen quickly. Now, I do want to mention that patients that have a transient ischemic attacks, that's a mini stroke, it's a warning for a stroke. These patients should be evaluated as well urgently because they've had a mini stroke. But definitely if you see a patient with a central retinal artery occlusion, you don't even refer to the retinal specialist. You go straight to a stroke urgent center. And it's important for us to know the closest stroke urgent center next to our practices. Now, some things that they'll do, we always think MRI, with and without contrast, but there's an MRI that's really specific for stroke, diffusion weighted MRI. And sort of looks at, the water molecule, the Brownian motion. So it's better to assess and better MRI to assess for ischemia and cerebral infarct. So it's better to pick up stroke changes in patients is what they'll do at the stroke urgent center. Also, too, if your patient is elderly and they have a stroke, don't forget that patients that are elderly and have a stroke, central retinal artery occlusion, are at risk for GCA, giant cell. They have temporal artery infiltration. So these patients should be evaluated urgently as well, just to save the other eye. They need to have a STED rate and a C-reactive protein assessment. Really quickly, I want to talk about post-surgical retinal emergencies. Some of us co-manage post-surgical care. Some of us see patients in our offices after surgery. When are those conditions an emergency and urgency for us? Well, anytime you have a patient that presents, whether it's post-surgical or due to trauma with a subluxation of the lens, and when the lens is subluxed into the retina, there's the high propensity for retinal detachment and other complications, increased intraocular pressure. This patient, you can see that it's pigmented around the subluxation. It had been there a while. This patient came from Haiti and came in with a painful eye. And when we take a look at the eye, we could see that the lens had subluxed into the retina, was touching the retina. This patient was referred urgently for assessment and had surgery within 24 hours to remove the lens. Any patient that has had cataract surgery, there's a lot of things we want to look for. One of the things that we're concerned about is retained lens material, whether it's in the front of the eye, but definitely in the back of the eye. If we see that, we definitely want to urgently refer that patient back to the surgeon for evaluation. It needs to be completely removed because it can lead to further complication. We also want to make sure our patients that have had surgery, whether it's cataract surgery, whether it's filtering surgery, we want to rule out any sort of leakage. These patients may run the risk for a positive Seidel test, so we want to do that. Decreased vision, and of course, shallow anterior chamber. These patients are at risk for not only anterior segment complication, but posterior segment complication. We have choroidal detachment. This particular case shows a kissing choroidal on a patient that had combination cataract mixed procedure and had a kissing choroidal detachment. So this patient was referred back to a surgeon urgently for evaluation and treatment. And, if you're working with the surgeon, as I did when I left Nova for a brief spit. I worked with an ophthalmologist that did cataract surgery, and patients that presented immediately after surgery, and we suspected they had a choroidal detachment on BIO assessment and on ultrasound. We could stop whatever, increase their cycloplegic drop and their topical steroids. We want to treat any leaks. And of course, the surgeon wants to evaluate these patients very quickly. And really quickly for time, one of the most feared complication for any surgery is endophthalmitis, especially in the back of the eye. We have front of the eye, exogenous and endogenous endophthalmitis. And OCT can help. Here's a patient OCT, could see the inflammatory cells in the vitreous. Of course, we talked about exogenous and endogenous endophthalmitis as emergency. Don't forget your patients that get intravitreal injection are also at risk for endophthalmitis as well as other complication. And I'm going to end there because I think I'm out of time, but I just want to let you know, with Bayview was out there, or Baby-O was out there, and it's not used as much because of some of the complications. So of course, injection, and then this is just highlighting again that this was recalled because of maybe not working well, but it was recalled. So Savismo has been recalled as of 10/22. All right, so true emergencies are same-day referrals. You want to definitely look at, whether they have MAC-ON, superior retinal detachment, malignant hypertension, artery occlusion, endophthalmitis. Timely referral time is usually 1 to 3 days. And remember that the emergency, whether it's right or wrong, the patient's perception really needs to be taken into consideration, and their feelings, because they're experiencing the emergency, even though it may not be a true emergency for us, but the patient perception is also important when we look at emergencies and urgent referrals. And with that, I want to thank everyone for taking their time to be here tonight.